Okay, we're ready to start our last segment for the afternoon. And it's a very important segment. It's where we hear public comments. And we do have several people who are going to be doing public comments today, and we are very interested in hearing what their positions are. This is a very important part of our session, and people write in to be able to do this. So we have a few. We're going to be starting a little early. We usually don't start till 4 o'clock with this section, but that'll allow us to be able to amply hear all the concerns. So let's get started, Helen.
Thank you so much, and thanks again for our public commenters for joining early, because I think this is the first time in history we've actually started public comments early. So good thing you joined early online. So our first public comment is going to be from Michael Ellenbogen, and then after Michael, we'll hear from Adina Lasser. So Michael, the floor is yours.
Can you hear me?
Can you speak up a little bit?
Can you hear me?
That's much better. Perfect. Thank you.
Okay. Thank you. For a long time, I have brought this up to Napa. While some progress has been made, we are far from where we need to be. The most impressive part is seeing CMS consider the CMS-1808-P proposal rule. While I believe it's a good first step, it falls very short of helping people with cognitive issues. If we really want to change what is needed for people, for all the people, we need to be bold and include the following, which Us Against Alzheimer proposed to CMS. They said it very clearly on what needs to be added to CMS-1808-P if we really are serious about changing the trajectory of truly helping people with cognitive issues. We would support the final rule that does the following. Number one, screens of admitted patients for cognitive issues, including dementia and delirium. Screening should include all patients over 65, as well as younger patients who are at risk for cognitive issues. Two, develop ways of making hospital staff aware that a patient has been identified as likely having cognitive issues. Three, trains and educates hospital staff on the appropriate ways to care for patients with cognitive issues who are in the hospital. Please take advantage of the proposed new rules and include these suggestions. We have a true opportunity to really help not only people with dementia, but so many others dealing with cognitive issues. This way, they will all get the help they deserve. Some additional comments. After attending AAIC 2024, I see from my perspective, while many are trying to do great projects, they fail to have a business-minded project manager driving the initiative, and they fail to include people living with dementia. Adding these people will lead to more expedited outcomes. I just formed a new world-class dementia training program by bringing together top organizations to work as one new company. This is unheard of in this field, and they are ready to train all staff in the hospital systems in caring for those living with cognitive impairment. These are all evidence-based programs. I will send you a longer version to be added to the record. Thank you.
Thank you, Michael. Our next comment is from Adina Lasser, and after Adina, we will hear from Nancy Murray.
Hi, everyone. My name is Adina Lasser. I serve as Public Policy Manager at the Alliance for Aging Research, and today I'd like to talk through 3 recommendations. First, with regards to screening for cognitive impairment, The federal government needs to prioritize screening for cognitive impairment as an A or B recommendation with the USPSTF. It's inexcusable that the USPSTF has maintained an insufficient recommendation since 1996, despite scores of published studies showing the benefits of cognitive screening and early diagnosis. In the past, one of the main reasons given for this low score was the lack of available medical therapies. Now, there are 2 disease-modifying treatments that have received traditional approval from the FDA, as well as an on-label treatment for Alzheimer's disease agitation, with more on the way. This must be included in NAPA's official 2024 recommendations. Second, CMS should be required to be transparent regarding its Medicare coverage with evidence development policy for monoclonal antibody treatments. Since they introduced the mandatory registry in clinical studies in July 2023, there's been no reporting or transparency by the agency. Instead, we have overblown estimates regarding the cost impact on the Medicare program, which assume uptake numbers that have not materialized, and also place undue blame on AD patients for premium increases. CMS should be held responsible for the patient impact of this policy. Lastly, CMS uses a poorly targeted quality measure related to the use of antipsychotics to treat neuropsychiatric symptoms of ADRD. These measures unfairly penalize smaller rural facilities and facilities that focus on treating complex cases of neurocognitive decline. The measures used do nothing to distinguish between appropriate and inappropriate use of these medications. There is now an FDA-approved treatment for agitation in AD patients, but patients have limited access to that care due to the outdated star rating metrics. We are also concerned the agency has not disclosed data on how many residents are involuntarily discharged from nursing homes each year due to these policies, and no transparency regarding residents being turned away at the door. Thank you very much for this opportunity.
Thank you, Adina. Our next comment is from Nancy Murray, and after Nancy, we will hear from Ryan Rotundo.
Good afternoon. My name is Nancy Murray, and I'm a board member of the National Task Group on Intellectual Disabilities and Dementia Practices, commonly known as the NTG. I'm pleased to announce that the NTG was recently awarded a grant by Special Olympics for our project, Changing Thinking, a national initiative to enhance access to critical health care and supports for adults with intellectual and developmental disabilities and dementia. This initiative will target guide program care navigators and will be offering culturally responsive educational materials, trainings, and protocols to address barriers to care that are disproportionately experienced by adults with intellectual disabilities and dementia from marginalized communities. So we are looking forward to learning more about the work of the Advisory Council on the CMMI GUIDE Model. In addition, my husband and I are the parents of 3 adult children with Down syndrome, one of whom has recently been diagnosed with mild cognitive delays. It is critically important that current and future clinical trials for medications that treat Alzheimer's disease include people with intellectual disabilities, especially adults with Down syndrome. Dementia appears in about 6% of the population of adults with intellectual disability over the age of 60, and 12% of the population over the age of 80 years. However, adults with Down syndrome show a much higher prevalence, among 60%, about 60% among adults age 60 and older. And there is also a higher rate among younger age adults with Down syndrome, about 20% among adults age 40 and older. Research demonstrates that across the United States, approximately 60% of people with intellectual and developmental disabilities who receive a Medicaid-funded service live with their families. In part, this is due to long waiting lists for services. Caring for an adult with an intellectual disability for 50 or 60 years, coupled with dementia later in life, results in emotional, financial, and physical strain on caregivers, especially elderly caregivers. So in conclusion, given the staggering percentage of people with intellectual disabilities, especially Down syndrome, who will be diagnosed with dementia, and the heart-wrenching impact on families, it is time that adults with intellectual disabilities be included in clinical trials for medications that treat Alzheimer's disease. Thank you.
Thank you, Nancy. Our final comment is Ryan Rotundo. Ryan?
Thank you so much, and thank you all for having me. My name is Ryan Rotundo. I am the Director of Programs for the National Down Syndrome Society. I also like to share that I am first and foremost the sibling of an amazing young woman with Down syndrome named Nicole. I won't tell you, well, I'll tell you her age. She usually fusses at me for that, but Nicole celebrated her 40th birthday in January. And for the first time, as we celebrated this birthday, knowing what I now know about the lifetime risk, the 90% lifetime risk for individuals with Down syndrome of developing Alzheimer's, it had a little bit of a different sense for me. Many of our birthdays, as you all I'm sure are familiar, are celebrated, and there's lots of hope and excitement. And this was the first year that, as celebrating my sister's birthday, we sort of were starting to think about some of the other issues that can come as these dates continue to roll by. And as you all know, and as Nancy has shared, individuals, again, with Down syndrome are at a 90% increased risk for developing Alzheimer's. And that is because of the genetic coding that is on the 21st chromosome. Obviously, having an extra copy of that makes individuals with Down syndrome more susceptible to this horrible disease. We do want to, as an organization, the National Down Syndrome Society wants to applaud the robust inclusion of Down syndrome in with more than a dozen mentions in the Council's draft recommendations. We want to also state that our community is committed to working with this Council and HHS to see these recommendations implemented. And the National Down Syndrome Society will continue to work with this Council and HHS to see these recommendations implemented, so that individuals like my sister and families like ours can continue to celebrate birthdays with hope and not that worry and concern for what's coming ahead. So we thank you so much for this time, and we ask that you would continue to move these pieces forward. Thank you so much.
Thank you, Ryan, and thanks to all of our public commenters. Adrian, I'll turn it back over to you.
Thank you. What an awesome day. We heard recommendations that have been really helpful from all of our committees. And then listening to the public comments, how important it is that we are doing screening within the hospital system and identifying people at risk at all ages. How important it is that we have quality measures. And again, I'm appreciating that he did notice how often we had listened to those who had reached out to us about Down syndrome and incorporated those recommendations. I wanted to call out the IDD training for the dementia navigators. And I think that's a very important one that I wanted to lift up, because as we kept talking about throughout the day, that a lot of people with IDD or a young onset dementia just not getting diagnosed in time, and our systems are not supporting them well. So I really appreciate that being brought up again today. So thank you, everybody. We're about to close, and we will be getting together again in October 21st. That will be the beginning of our new cycle year, and that one is going to be on clinical care. It just so happens our clinical care committee is meeting this Thursday from 4 to 5, and we'll be starting to talk about that agenda. So thank you, everyone, for attending. Goodbye.
Produced by the U.S. Department of Health and Human Services.